There is a vast amount of literature and publications on the topic of vasopressors and inotropes, and in these videos, we're going to try to cover some of the more recent and significant papers on this topic. So the first one we're going to talk about was published in the New England Journal of Medicine in 2010. It was titled, Comparison of Dopamine and Norepinephrine in the Treatment of Shock. It was a multi-center randomized controlled trial of 1,679 patients with vasopressor-dependent shock who were assigned to receive either norepinephrine or dopamine. The study showed no difference in mortality between the groups at 28 days. However, they did find that arrhythmias were more common in the dopamine group. There are other studies that illustrate this point. For example, another study published in Shock in 2010 titled The Efficacy and Safety of Dopamine versus Norepinephrine in the Management of Septic Shock was a quasi-randomized controlled trial of 250 patients that looked at the use of dopamine and norepinephrine in vasopressor-dependent septic shock. The results also showed no significant difference in 28-day mortality in patients receiving dopamine, and also showed that arrhythmias were more common in the dopamine group. Remember, we did talk about arrhythmias as being one of the side effects of dopamine, and here are just some real-world examples to illustrate that point. There are many studies like this that show no significant difference in mortality between different vasopressors. However, a meta-analysis of 6 randomized controlled trials published in Critical Care Medicine in 2012, which was titled Dopamine versus Norepinephrine in the Treatment of Shock, showed that mortality was higher in patients receiving dopamine. So what does that mean for dopamine? This doesn't mean that there's no place for dopamine because of its adverse effects or because of a difference in mortality. In fact, dopamine is one of the recommended medications to give to a patient with symptomatic bradycardia. Given the studies that we just talked about, dopamine may not be the best first choice for cases of septic shock. In fact, many recommendations label dopamine as a second-line agent for septic shock and warn against the use of dopamine in patients susceptible to dysrhythmias. But of course, these are just guidelines and should not be strict rules that dictate the management of your patient. Your choice of vasopressor should always be tailored to your patient and their clinical setting.